Return to cervical lymphadenectomy general considerations. See also thoracic duct and chylothorax general considerations. Marginal mandibular nerve weakness, ramus mandibularis, level 1 neck dissection, extended. Recurrent pleomorphic adenoma. Myositis ossificans of the neck surgical treatment heterotopic bone formation after trauma. General considerations. 1. Indications. Elective treatment of N0 neck with significant risk of regional metastasis. See cervical lymphadenectomy general considerations protocol of selected N+ neck dissection. Serves as a staging procedure and can be used for decision-making regarding the need for adjuvant postoperative radiation therapy. In selected groups of patients with N+ disease, the use of selective neck dissection, SND, is gaining support. When indicated, application of postoperative radiation therapy reduces the rate of regional failure. Recent reports have further diminished the extent of selective neck dissections to include NIDUsectomy, or removal of only the abnormal metastatic residual after chemoradiotherapy, Hashmi 2022, Bertlick 2022. 2. Contraindications. Extensive neck disease. Evidence of extracapsular spread by clinical or radiographic evaluation, i.e., fixed nodes, involvement of deep neck muscles, cranial nerves, sternocleidomastoid muscle, internal jugular vein, carotid artery, would require more radical dissection than a selective neck dissection. 3. Extent of neck dissection. The selection of which levels of lymph nodes require removal depends on the location of the primary tumor and the predicted spread of local disease to regional sites. 4. Historical perspective. The radical neck dissection was first described in 1906 by Crile, based on the Hallstedian concept of en bloc resection. The purpose was to effectively remove all of the lymph nodes present in the neck and their interconnecting lymphatics. It was the standard of care for the following 70 years. However, in addition to nodes and lymphatics, it also removes the SCM, sternocleidomastoid, submandibular gland, tail of the parotid gland, internal and external jugular veins, cervical sensory nerves and cranial nerve 11. Suarez later realized that cervical lymphatics are contained within fascial spaces, consisting of the fascia covering the submandibular glands, carotid sheath, SCM and deep cervical muscles and nerves, and he incorporated this fact into his neck dissections. In 1967, Ferlito, as well as Boca and Pignataro, coined the term functional neck dissection, describing procedures that remove all the lymphatics but preserve non-lymphatic containing structures. We now refer to this as a modified neck dissection. Further advancements have demonstrated that depending on the situation, not all levels must be explored, thus, developing the concept of the selective neck dissection. And 5. Anatomical considerations. Levels of the neck. Level IA, submental triangle. Boundaries. Anterior belly of the digastric muscle and the hyoid bone. Level IB, submandibular triangle. Boundaries. Body of the mandible and the anterior and posterior bellies of the digastric muscle. Level 2. Upper jugular nodes. Boundaries. Anterior. Border of the stylohyoid muscle. Posterior. Posterior border of the sternocleidomastoid muscle. Superior. Skull base. Inferior. Level of the hyoid bone. Clinical. Carotid bifurcation. Surgical. Level 2 is divided by the accessory nerve into levels IA, anteriorly, and IIB, posteriorly. Level 3. Middle jugular nodes. Boundaries. Anterior. Lateral border of the sternohyoid muscle. Posterior. Posterior border of the sternocleidomastoid muscle. Superior. Hyoid bone. Inferior. Cricoid notch, clinical, omohyoid muscle, surgical. Level 4. Lower jugular nodes. Boundaries. Anterior. Lateral border of the sternohyoid muscle. Posterior. Posterior border of the sternocleidomastoid muscle. Superior. Cricoid notch, clinical, omohyoid muscle, surgical. Inferior. Clavicle. Level 5. Posterior triangle. Boundaries. Anterior. Posterior border of the sternocleidomastoid muscle. Posterior. Anterior border of the trapezius muscle. Inferior. Clavicle. Level 5 was subdivided into level VA, superiorly, and VB, inferiorly. Levels VA and VB are separated by a horizontal plane marking the inferior border of the anterior cricoid arch. VA, spinal accessory lymph nodes. VB, transverse cervical nodes and supraclavicular nodes, with exception of the Virchow node, in Level 4. Level 6, nodes of the anterior compartment, pretracheal, paratracheal, precricoid lymph nodes. Boundaries. Lateral border of the sternohyoid muscle. Superior, hyoid bone. Inferior, suprasternal notch. The spinal accessory nerve, C, posterolateral neck dissection variant of trapezius innervation. The spinal accessory nerve is derived from motor neurons found in the spinal nucleus, extending down to the level of C5. This nerve enters the skull through the foramen magnum, only to finally exit the skull via the jugular foramen. It usually emerges posterior and lateral to the internal jugular vein, however 30% of the time it exits medial to the IJ, whereas 3 to 5% of the time it actually splits the vein and courses through the vessel. It then pierces the deep portion of the sternocleidomastoid muscle at approximately the level of the lateral process of C2, to then exit the posterior portion of the sternocleidomastoid, traversing the posterior triangle, where it then disappears under the anterior surface of the trapezius to innervate this muscle. Between the jugular vein and the sternocleidomastoid muscle, the accessory nerve overlays the transverse process of C1, along with the occipital artery. Innervation. This nerve innervates the sternocleidomastoid and trapezius muscles. The great auricular, transverse cervical and lesser occipital nerves emerge from the prevertebral fascia and travel anteriorly, superiorly, and inferiorly from a point along the posterior border of the sternocleidomastoid. The spinal accessory nerve can be identified approximately 1 centimeter superior to this point. The emergence of the nerves is sometimes erroneously referred to as Erb's point. Wilhelm Erb, 1840–1921, was the father of modern electromyography, and identified a surface point at which the brachial plexus could be transcutaneously stimulated. This point is located several centimeters inferior to the point of emergence of the sensory cervical plexus nerves, Tubbs et al., 2007. This accessory nerve can also be found entering the anterior portion of the trapezius muscle approximately 5 centimeters above the clavicle.